Welcome, and thank you for joining us for this month's Learning and Advocacy series. Our topic today will be exploring care coordination, mobile integrated health. We have a really amazing panel of guests with us today. I'm really excited to hear from each of them. But before we get to that, we have some general housekeeping reminders. Please use the chat box throughout the session to share your thoughts and questions. That will be monitored by Stacy. If you are able to do so, please have your camera on, and we always understand if you can't. This meeting is being recorded and will be available for viewing at a later date. Now I'd like to get us started with our land acknowledgement. We begin by acknowledging with humility that the land where we are today is the territory of the people of the Salish Sea. Their presence is imbued in the waterways, shorelines, valleys, and mountains of the traditional homelands of the Coast Salish people since time immemorial. And then as usual, we have the link to native-land.ca where you can learn more about the Indigenous land where you're spending your time. And that is continuously being updated, so I do recommend going back to it from time to time just to see if anything has changed either in your current location or places that you've spent a lot of time before. Okay, and then our agenda for today. We'll have a quick review of the network learning approach, then we'll have introductions of folks in the Care Coordination Cohort, and then we'll have a panel discussion with our panelists about mobile integrated health. Following that panel discussion, we'll move into small groups. That'll give us a chance to reflect on what was shared today, make connections with other members of the network, and then we'll have some closing thoughts and next steps. So the network that we're building right now is a learning advocacy and collaborative action network open to all community members and organizations. Within the network exist cohorts, a strategy of the network, which include opportunities to engage in collaborative action across the region, as well as a chance to further the learnings from the network learning series, which we're doing today. The monthly collaborative action network meetings are open to all network members as a time to bring everyone together for our overall vision, which is a priority for North Sound ECH. All cohort members are all cohort members are network members, but not all network members are cohort members. And within the cohorts, folks are engaged at multiple levels based on their capacity and priorities. And then if we can go to the next slide. Through the monthly learning and advocacy series, we are living into our shared beliefs that all community members deserve well-being, that we have inherited legacies of systemic racism, which have perpetuated trauma and exclusion, particularly among BIPOC communities. Sorry, I'm stumbling over my words a little bit today. It happens. That we can work together to create new legacies and the conditions to ensure belonging for all people in our region, and that we are accountable to each other and to the well-being of future generations. Each of our monthly learning series builds upon these shared beliefs. I know that for me, today I will be reflecting on our last learning session in July, prior to the convening that we held in August, which was about the impacts of stigma and how to reduce the detrimental impacts of stigma. So as I'm listening to the panelists today, I'll be thinking about how stigma shows up in traditional models of care, how that can affect the care that is received by folks, and how that can affect health outcomes over the lifespan. I'll be listening for new ways of connecting and providing for communities that start working to dismantle those negative impacts, those inherited legacies, and the work being done through models like mobile integrated health to create new legacies of caring and belonging. Thank you again for joining us on this journey, and now I'll pass it over to Rajdeep. Thank you.
Hello, good morning all. Thank you all for joining us today and learning more about the Mobile Integrated Health and Care Coordination Cohort. I will kick it off by kind of sharing a high-level overview of what the Care Coordination Cohort is, and then sharing some more deeper definitions about the work groups that are among the Care Coordination Cohort. And that is a mouthful. Say that 3 times fast. The Care Coordination Cohort was formulated to help community members navigate a complex, disconnected, and disorganized system of care and services. We're also working to help community members find ways among the current system that is healthcare. Within the Care Coordination Cohort, we have 3 work groups. One of them is the Care Coordination Hub, which is designated to grow the regional North Sound Community Hub by sharing an information platform, advancing workforce strategies in support of community health workers, and acting as a network broker to bring payment to community care coordinators. We also have cross-sector care coordination, and this work group addresses the needs of community members who intersect with multiple systems and sectors, those who are familiar faces to emergency departments, courts, housing, and advocacy agencies because they have clinical, social, or legal or financial needs. And then lastly, the work group that we're learning more about today, the mobile integrated health, which predominantly focuses on care coordination that occurs outside of the clinic or office setting. All right, next slide, please. So a little bit more information about mobile integrated health and a little bit more of a broader perspective on what this is. Mobile integrated health is patient-centered, an innovative delivery model offering on-demand, need-based care and preventative services delivered in the patient's home or mobile environment. Mobile integrated health offers an innovative approach to keeping patients from falling through the cracks created by fragmented and disjointed care. Mobile integrated health can look like many different forms of community service lines. Few of them will be speaking directly with those folks here today, but those are not limited to just the folks that are here today. So some of the programs include community resource paramedics, alternative response programs, substance abuse programs, and then also diversion programs. And those are just to name a few. And so now that we're familiarized with what care coordination is, and now that we have a little bit more of an understanding of what mobile integrated health is, I will go ahead and pass this on to Liz, who will introduce our panelists today.
Thanks so much, Rajdeep. And I am Liz Baxter, use she, her pronouns, and I am the CEO here at North Sound ACH. But the reason that I'm here helping with this panel is that I'm part of the Care Coordination Cohort, and together with Erica Littlewood have been co-leading this mobile integrated health work group. I have about 20 plus years of designing and building care coordination programs up and down the West Coast. And so it's just really exciting for me to be joining this panelist, and I look forward to learning from them with you. So Natalie, I know we've got some slides that we're going to use as we introduce folks, but the 4 folks on our panel, I'm going to ask them to actually introduce themselves, and a couple of them have got some slides that they're going to use as they're doing those introductions. And so, Alessa, I'm hoping that you can introduce yourself, kind of how your organization is connected to mobile integrated health, and tell us a little bit about the work you're doing. And you have like 2 to 3 minutes.
Perfect. I'll try to make this fast. My name is Alessa Lopez-Castor. I am a nurse practitioner and the Associate Medical Director of Consistent Care Services here on the West Side in the Snohomish and Skagit areas. First of all, I'd like to speak about street medicine, which is definitely a form of MIH. Street medicine includes health and social services developed specifically to address the needs of the unhoused. Care is delivered directly to them in their own environment to eliminate barriers to the care of access. Access to care. Trust is established by respect and consistency. The street medicine care model, as Rajdeep was saying, it's a patient-centered care model that is relationship-focused and culturally sensitive. We meet patients in the field where they're at. respecting their reality and on their terms. The street medicine programs, they are in over 140 cities across 27 countries and 6 continents. So really, street medicine had been it was very fragmented at first. It had been, different programs thought they were the only ones that existed. And then an international street medicine program was developed in 2015 that kind of brought everybody together so that they could share information. As you can see, our we call it a mobile clinic on wheels. We were able to purchase that about 2.5 years ago from our ACH funds. And it was right around the time when COVID hit. So it was really essential to have this. We were able to provide tablets and internet access to patients who normally didn't have that access, but yet they were expected to do telehealth medicine with their PCPs. So this trailer has just been an asset to us and the community. Next slide, please. So the street medicine component, as I said before, I'm a prescribing nurse practitioner. My team consists of myself, an RN, and we have client health or client advocates, some of which are our medical assistants. We volunteer and partner with a street medicine group called Mercy Watch, and we volunteer these services to go, whether it's the Men's Gospel Mission out in front of the diversion clinic. Sometimes we'll do evening clinics where we go out into a parking lot. Again, the foundation of street medicine is consistency and meeting them where they're at. At that time, we triage the patients. Some may actually need a higher level of care. We provide resources to make sure that they're signed up for insurance, to make sure that if they have an abscess that hasn't gone septic or that they haven't, developed a full-on cellulitis, if it's ready to be IND'd, we'll do that in the field. We follow up with prescribed antibiotics. We follow up. It's consistency. They know that every Wednesday night we are there in that parking lot and that there's no judgment. I think the biggest and most important thing is that we are bringing healthcare to where they're at to try to avoid barriers of care. And it's life-saving to a lot of these folks. It really is. So back to the consistent care side, we do all of that, but we also are an emergency department diversion program. We offer intensive case management. The GOSH program, I don't know if a lot of you are familiar with, that is housing navigation for those who have behavioral health diagnoses and were ITA'd for greater than 14 days. FCS offers housing navigation as well as employment navigation. Again, like I said, I'm a prescriber, so I definitely can bridge with MAT treatment until we can get them into an outpatient provider. We do naloxone distribution. We provide vaccines for COVID-19. That was essential, and that is something that I would really like to work with the ACH in going into the rural communities and providing any new additional vaccines that may come down the line. I also bridge medical health services, so clients that may have been inpatient, but they can't establish with an outpatient provider for 3 months. I'm able to bridge that medication. We give a lot of Invega injections out in the field. But the most essential thing to me with consistent care is our community partners and our collaboration. We work with 6 area hospitals, local PDs, the fire departments, EMS, MCOs with Washington State, primary care providers, and behavioral health and SUD providers. So I hope I'm not over my time limit. I know that's a lot of information, but I truly, heart of hearts, my background is emergency medicine, and I really believe that mobile integrated health is the wave of the future, and it's the way of providing inclusion to everyone in our community.
Thanks so much, Alessa. Sounds like a good segue to Jim Reinhardt. And Jim, you're going to talk about community resource paramedicine. And so take it away. If you want to start by introducing yourself and kind of your connection to mobile integrated health.
Yeah, sure. Yeah, thank you for letting me be here today. My name is Jim Reinhardt. I've been working full-time in the fire and EMS for, I guess, over 30 years now. I am a paramedic firefighter, and currently I am the chief of the emergency medical services for Snohomish County Fire District 15, which is also known as the Tulalip Bay Fire Department. We serve the people who live, both tribal and non-tribal, who live on the Tulalip Indian Reservation. I'm also a certified community paramedic. I attended the Hennepin College, which certifies paramedics in this higher branch out training. And community paramedicine is something that I'm very passionate about. I've been working 911 calls for the majority of my adult life, and there was always a real gap in what we were able to do for a certain genre of our patients, a certain subset of our 911 interactions. You know, we would go to a 911 call. Sometimes they're critically ill. Sometimes they're not. Sometimes they need to go to the emergency department. Many times they don't. But we would go to these 911 calls, and then we would either take them to the hospital or not. Our interactions with those patients were relatively short, and we saved a lot of lives. I, for my part, done some pretty good that way. But there was always a real a gap in the type of care and services that we were able to provide to people who neither needed to go to the emergency department or had access to care. And so, and part of that, of course, is community paramedicine. And this slide right here, I guess how I would go through this one slide is just an overview is the top thing, to be able to meet these needs. And you normally think of the fire department and your firefighters, your EMTs, your advanced life support paramedics as responding to life-threatening emergencies. And clearly that's often the case. But those paramedics, those firefighters and EMTs can only be available to respond to those 911 calls when they're in service and able to, to go out. And a lot of times we're being wrapped up and our time is being utilized dealing with patients who are not in life-threatening illnesses or injuries, but they have a myriad other health and psychosocial issues that still are demanding a great deal of our resources and our time. And they also need to be connected to care. And so, and that kind of brings up the other pictures. You have issues with severe depression. You have individuals who are on really invasive durable medical equipment, and they're also living in environments that including hoarding, living in situations that are untenable as far as the health and safety of the person. Isolation, particularly in the geriatric or the elderly community. There's also a very imperfect understanding on how medications should be taken, when they should be taken. And of course, there are those who are dealing with substance abuse problems. And what I've experienced and what all EMTs and paramedics experience is often the patients that we're seeing aren't just dealing with one of these issues. There are a lot of these that are real comorbid factors. And I've had many patients who are dealing with all of these things. So what community paramedicine is fundamentally, it's kind of a smarter approach for fire EMS to deal with patients who really need advocacy, but the normal EMS operations don't really provide that. And so on the left-hand side there, the community paramedic role, and this isn't exclusive, but these are things that throughout the course of my community paramedic roles, this is what I do. So we will do medical assessments. And a lot of times for on the Tulalip Indian Reservation, the clinic will call and say, hey, we have somebody that hasn't shown up for their appointment. We think they may be really sick. Will you please go evaluate them, find out if they can be treated at the clinic, why they didn't show up, if they need to go to the emergency department. Chronic disease education. That's a big part of what I do, explaining not only how to treat your congestive heart failure, how to treat asthma, issues with COPD. We explain how to, hopefully live a better life dealing with those illnesses. Medication reconciliation. And that's a big one too. Understanding, explaining to a patient when you should take these medicines, when you shouldn't, what medications you should not be on anymore, things like that. And the list kind of goes down. You can read it, and I won't go into depth right now. But community paramedicine is, from my perspective, from many of our perspectives, a much smarter way of dealing with these types of interactions. So thank you. And yeah, and so this slide, community paramedicine is many things, but I can tell you some of the things that it is not. And this is a very important distinction. Our main role in the fire and EMS is clearly to respond to emergencies, particularly those that are life-threatening. The community paramedic kind of fits into this role of a patient-centered centered care, but we are not social services. We are not home health providers. We are not MHPs. We are not primary care providers like Alessa is. However, because of the nature of the experience of working in fire EMS, we really we unfortunately dabble in all of those different areas, with perhaps the exception of being, of course, inpatient hospital staff. But what we do is we connect those patients to social services, to home health providers. And the people who work in those areas, those providers who come into the home or reach out to the patient on the street, as was mentioned, they are really the experts at dealing with connecting social services, dealing with sometimes very deep-seated mental health issues. Our community paramedics aren't, and not only are we not trained into that depth, we don't really have the bandwidth to take on that fight, if you will. But what we have found is through a 911 call, we'll have an interaction and identify a patient who is in desperate need of sometimes all of those things. And we sort of act as a bridge to connect them. And lastly, the community paramedic, as opposed to during a normal 911 call, where your interaction could be up to maybe an hour and a half, a community paramedic often will establish sort of long-term health relationships, professional health relationships with a person in their community, to monitor them, to act as sort of the advocate to make sure that these other things are happening, these other connections are being made. And fundamentally, that's it.
Great, thanks so much, Jim. So next, Mike Hilley, if you want to introduce yourself and kind of how you're connected to mobile integrated health.
Yeah, thank you, Liz. My name's Mike Hilley. I'm the Emergency Medical Services Manager up here in Whatcom County. Almost 5 years coming up on that anniversary. And like Jim, I have been a paramedic for right at 30 years, starting in Juneau, Alaska, and then working out of King County for about 25 of that, and previous time in the U.S. Coast Guard for 10 years as a medic and EMT. And so, Jim really covered a lot of the gaps in what we see from a 911 perspective or a paramedic EMT perspective when you go in somebody's homes. And one of the things I'm always reminding people is that EMS is the eyes and ears of public health. They're the eyes and ears of the doctor. And we see things happening usually way before they become a trend, if you will. And especially when we're talking about frequent users of the system or familiar faces that we see a lot. And I know for my career, as a paramedic, we get in and do our thing and try to save a life and solve that problem in 15 or 20 minutes. But it's always left a sort of a knot in my gut to know that somebody that I'm dealing with or treating at that moment needs further help. They need more intervention. And so from an administrative point of view, I always think about how can we connect all these things to the larger healthcare system. This is a pretty new endeavor for the fire department, really, in the last 10 years, where we partner with outside agencies to help navigate patient to the right care at the right time and avoid becoming frequent users of the system. And our desire is to not necessarily keep people from frequently using the system, but to catch those things before they become a frequency, because we see those things that happen beforehand that could actually be intervened on pretty quickly if they had the right people involved and the right care involved. And this includes the relationship that Jim talks about with the physicians and the clinics, et cetera. And so one of the things that we'd like to learn, at least from my perspective, is what does this mean for clinics and hospitals and physicians and social services out in the community when you get a call from a community paramedic saying, I've got a patient that we want to help out. And really, in the other direction as well. I get calls frequently from a clinic or a social worker or an organization saying, "Hey, Mike, we're seeing this. We have this one patient. We know they're frequenting EMS. Is there something we could help EMS with that intervention?" And so we think about a lot about this hub and spoke idea of connecting services. And here in Whatcom County, we are really headed that way with our GRACE teams, which are teamed up with our community paramedic. They go out, and the social worker, case manager, actually provides some of that case management, while the paramedic can help navigate certain areas in the EMS system where they can have those interventions. And finally, I'll say, really for us, it's about that intersection. It's about that opportunity to intervene at the right time. I got a call from one of our representatives asking, what can EMS do to help the court system out with patients that have these frequent medical problems? And my response was, well, I'm not sure how we can help the courts out, but I can tell you that we can help during these engagements. We engage these patients at a time when we can make a critical decision to divert, other than just having to say, okay, I have to put this person in jail, protect them from themselves, protect them from others, because there's no other place to go. So here in Whatcom County, we're developing programs around diversion to a crisis stabilization facility for both mental health and SUD. We want to see if we can engage and partner with other organizations that would help us in the street relative to Alessa's program with street medicine. And how can we get out there and intervene and prevent before a person becomes not only a frequent user of the EMS system, but the hospital and the multiple other services out there that may not necessarily be connected. And then one final thought was that the data is an issue. We need to connect all these data systems, all these patient care systems, so you have a more broad understanding of patients' continuum of care. We know many get care up and down the I-5 corridor, or even in your own community. They may not be connected with each of the providers to know what they're doing in that case management. So we're up here working to create a health information exchange, so any type of provider can log on to this system and understand where that patient's in that care continuum. So I'll stop there. Those are some of the things we're working on in Whatcom County. And I know from our group perspective, some of the things and ideas that we want to progress to the state level that would get some attention on supporting these programs, designing reimbursement, training, education for them as well. So thanks for the opportunity to speak, and I appreciate being here, Liz.
Thanks so much, Mike. And then the last on our panel is Adam Davis. And so Adam, if you want to introduce yourself and your connection to mobile integrated health.
Yeah, thanks, Liz, and thanks for the opportunity to be here today. My name is Adam Davis, he, him pronouns. I work for an organization in Washington State. We're a 501c3 nonprofit called Health Commons Project. I'm a clinician by background, similar to Alessa. I'm a family and psychiatric nurse practitioner, and in 2012, had the opportunity to work with Puget Sound Regional Fire Authority down in South King County, was previously Kent Fire, to help launch one of the first CPMIH programs in Washington State. In 2020, I left Puget Sound to launch this new nonprofit organization called Health Commons Project. A little bit about Health Commons. We describe ourselves as a public health accelerator. So similar to commercial models, if any of you have heard of groups like Y Combinator or Techstars, we help local schools, fire departments, and other community-based organizations put the right partnerships together, the right services together, the right technology and funding together, so that they can set up and scale new health and social services. So we don't put shots in arms or swabs in noses. We're really here to make sure the boots on the ground providers have what they need to be successful. Currently, we operate two programs sponsored by Washington State Department of Health. Our first one is called Learn to Return, which is a program that helped reopen the schools during the pandemic. We've enrolled over 500 schools and school districts. in that program to help them set up COVID-19 testing and vac services. And we're excited to launch our second program here, Walk COVID-19, which is really focused on fire departments and CPMIH programs to help them set up lightweight and sustainable COVID-19 services. We're just starting to do a soft launch of that program with a few fire departments in Washington State, really focused on areas where access to testing may be difficult. But if any fire departments on this call are interested in getting supplies, funding, and support they need to set up COVID testing services, please reach out to us. I'll drop my colleague Hannah's email in the chat. And yeah, that's just a little bit about how we support fire departments and CPMIH programs.
Great, thank you so much. And so there's like 3 questions / comments so far that I've kind of grabbed from the chat. And so since I prepared you all for this, I'm going to switch this up a little bit just to kind of manage time. So wondering if, I'm probably going to go in the inverse order. So Mike Cohen asked a question that we had kind of on the list for you all. And it's just about like, how are things funded and what gets in the way of getting funding for these kinds of programs? Mike, maybe I'll start with you, and then Alessa, if you wouldn't mind, just because you're coming from 2 different kind of scenarios.
Yeah, thanks, Liz. Well, a couple of funding sources for EMS in Whatcom County. First off, we have a countywide EMS levy that just covers all of our basic response operations, as well as some prevention and outreach programs. And so through that, we're able to fund 3 of the community paramedics that are operating with our GRACE program with the social workers. The GRACE program has actually grown from a grassroots effort. Actually, it started out of an organization called WAHA. It was a Whatcom County Advancement for Healthcare Initiatives, and that was sort of a pilot group that got us in that into that business here about 8-9 years ago. Not sure where that funding came from, but it was some startup funding through that organization, and I'm quite sure it was grants and state. But right now, through the GRACE program, we have repositioned. We had a short stint where we contracted to CMAR for the case managers and the nurses, et cetera. However, we wanted a more robust program, and actually the electeds wanted a little bit more flexibility in it as well. So we brought the entire program into the county health department and created a new division called the Response Division, which houses our LEAD program. It houses our GRACE program, which is a ground response and coordinated engagement program, as well as the up and coming alternative response program, which is going to provide an unarmed response that will tackle our low acuity calls out there on the street. So these are your people sleeping on the street, sleeping in the car, maybe acting out in a small mental health way, and to some degree, some response for our substance use disorder problem in the county, and hopefully maybe a bridge to MAT services through intervention on the street. All of that is funded through some local funds. We did get some state short-term funding for 2 years through Representative Rule and Representative Shoemaker, who have pioneered, supported this in our community, and actually are really eager to see how this is going to work out. Then there was some small grant funding for that program as well, but the lion's share of it is through our local health department funds, as well as state funds that contribute for the startup, not only for the teams, but also for the Crisis Stabilization Center that was stood up in January, 16 beds mental health, 60 beds SUD services, where we can divert to some degree from the ED for those types of patients who are willing to take services there. So that's generally in a nutshell how we're funded in Whatcom County for those programs.
Don't forget some of those ACH funds that went.
Yes, and we had a nice, in fact, the ACH funds back in 2018 allowed us to fund, at the time, a second community paramedic for the county. And those funds were essential for the startup because that was the proving phase from the county perspective, out in the county, because the city had been operating one community paramedic at the time. When I got here, we were grateful for those funds, which kickstarted that. Interesting, once that community paramedic was embedded, there was no turning back. So now we had it fully funded out of the levy once that program has progressed through our county council. So it was a great way for startup. Thank you, ACH. Oh my gosh, that was such a great thing for us.
So Alessa, I'm gonna maybe tell you what I didn't hear from Mike. And so the same question to you. What I didn't hear, health plans reimburse for the work that's happening. So can you talk about like how your programs are funded?
Yes, so Mercy Watch is different. Mercy Watch is a nonprofit, and they thrive, or they survive off of grants and personal or private donors. The teams are volunteers, usually retired physicians, or providers, retired RNs. That is what's fueling the work source out there. Recently, in the last year, we've been joined by Washington State University residents, which my heart explodes with that, because we're teaching the fundamentals of compassion and street medicine to people who are going to go out and affect our community and our world. And I'm just so excited about that. So that is Mercy Watch. Consistent Care, we are contracted with Washington State MCOs. So our funding, we are funded by MCOs and assigned high utilizer patients out of the ER via the MCOs.
And so I assume there's some payment mechanism then from the health plans.
Yes, they send us a list each month of patients that are high utilizers of the ER, so that we can go out and assess, as what we can do to change that behavior.
Yeah, one of the conversations that we've had like lots of times in lots of the 5 counties, that one of our deliverables was to reduce ED utilization, but some of the strategies to do that aren't actually reimbursed. So you hear a lot of grant funding and county levies and things. It's a very, very interesting dynamic. So I'm going to start with Adam and Jim, and I want to kind of go to another comment that showed up in the chat, and it was about just some language that participants are hearing. That all of our work kind of ties to our equity work, and we have a number of folks on the call who have kind of a diversity, equity, inclusion, belonging background, and I think it was Samara that raised some questions about just the language that's being used. Are you dealing with folks, or are you working with folks? And Samara, please feel free to unmute yourself if there's a further question. But Adam and Jim, just wondering, like, how does DEI work? How does that influence what you do? Like, what kinds of opportunities and trainings are available for the teams you work with?
Well, as far as so that I understand the question, what type of training for our community paramedic staff? Our community paramedic program is perhaps unique in the state, in that we are, first and foremost, we're a county fire department, but we are wholly located within the sovereign nation of the Tulalip tribes. And the training that our staff, not only our community paramedics, but our frontline EMS staff undergoes, frankly, circles around understanding the history of the Tulalip tribes, what the community looks like. And it's a fantastic, very interesting and dynamic community. And so our staff, at a very early onset in their employment, in fact, learns about the Treaty of Point Elliott, about boarding schools, about health inequities, about significant impacts to the community that we're serving. And that's a real fundamental cornerstone of not only our medical training, but of course, training our staff to be able to really better serve I guess you would say, our target audience. And it's probably one of the most interesting places I've worked in the arc of my career. It is, it's nuanced, and there are no stereotypes. Everything is very dynamic, particularly with the people that you're dealing with in the community, from two-spirit patients to people who are dealing with significant generational trauma, and we are constantly dealing with training ourselves to better serve those patients by taking training sessions on how to deal with trauma-informed care. And a lot of the training that our CRP program has undergone has been supplied actually by the ACH. And I don't know if that answers adequately the question. I hope it does.
Yeah,
Adam?
and I think that you know, Adam, as you jump in, the comment that was in the chat was just like how important language is when you know, we're talking about the work that happens in community. And since this is something that's we're taking you out of the clinic setting, out of the hospital setting, and going into community, you know, just how important that is. But Adam, anything that you might have to add?
Nothing really to add, Liz, on the language or the use of the word. I think deal was maybe the dealing with patients versus serving patients or providing care to patients. I know as fire agencies and schools and new, providers are kind of learning how to do these new jobs and find different ways to serve their community. There's a lot of I think word salad and new terminology that people are trying to get smart on. So we have a shared language and understanding across different provider types about how to talk to each other and how to serve our community members. In terms of kind of your DEI question, Liz, I think we at Commons got into this work. A major reason is how do you expand equitable access to care? And during the COVID-19 pandemic, we saw that there were a lot of poor health outcomes that were associated with people not having language translation services or culturally care that matched their culture. And so we've been working hard with our sponsors at Department of Health to figure out, how do we ensure that any marketing and promotional materials are going to be translated into, all the different languages in that community. How do we partner with community-based organizations on the ground who know and serve those community members and give them the tools and the resources and the funding to put together these marketing and promotional materials and getting people activated and connected to services. So I think there's been a lot of good learning from our group about how we can really work at the grassroots to make sure those closest to the people that need care have the tools and the resources that they need.
Liz, if you don't mind, I'd like to respond shortly to that too. The fire service in general, police officers, the healthcare system in general have long enjoyed internal lingo, internal sort of language that was sort of specific to our business. One example is I used the term frequent flyer throughout my career, I don't know how many times, not really thinking about how that might be received by somebody, and so we've changed language like that. But inside our fire service, with our gallus humor and how we deal with these stresses of the job, there's been a lot of language invented that is unique to us. And I think that's the biggest part of this learning, which is how do we push this language down? When I talk about DEI and health equities, many of my administrators go right to their pocket, which is related to hiring. But that's not really what we're talking about. What does health equities mean at the hands of an EMT at 2 o'clock in the morning, when they're trying to serve that patient as best they can? And so I've seen paramedics over the years use language that, looking back on it, was reprehensible, to be quite honest with you, because it shaped that relationship at that moment between the patient and the provider. So I think it's important for us to move ahead and learn these different languages with all these considerations that we're talking about right now, because that's some old school stuff. I mean, that's 50 years of embedded language in an industry that deals with bad things all the time. And I think that's some labeling that has just been on it for a lot of years. It needs to change.
So Mike, just so we leave some time for like our partners to be able to talk to each other, I'm gonna do like a rapid question to the four of you. And the question is, like, you're looking out 3 or 5 years from now, like what's different than what you've got today? So Mike, I'm gonna start with you and then go to Adam, Jim, and then Alessa.
Well, my dream for 5 years from now is that we have an integrated system where all of these components come together. We have shared language. We have shared understandings of what our role in the community together. And I think the biggest thing is to understand how we integrate all this. You know, we've lived in a silo for a long time in the fire service. And, you know, we weren't invented for this work back in 1965 when the famous DOT white paper came out and said, you need to provide some type of care for, you know, mortality, morbidity in the streets of America. And so look where we are today. So I think the 5-year future is, how do we further integrate that? How do we bring EMS more into the healthcare system as a whole? And then once again, how do we share this information and those equities that we talk about? That would be my dream for the 5 years.
Adam, what's different when you look out forward?
That's a great question, Liz. Yeah, it's an exciting time to be in the health and social service space. I think we're going through an industry transformation that, I think is very similar to retail and banking and newspaper, where we're starting to see, a real focus on consumer, client, community member as the focus. How do we organize a set of services around the individual and use tools like mobile and digital to really, provide those services. So I'm hopeful and optimistic about the future. I think in 3 to 5 years, what I'd love to see is these small kind of neighborhood networks starting to come together and professionalize. So, how do we start putting in real infrastructure between local fire, local school, local CBOs, local hospitals, to make sure we have the right people, process, and systems in place to be able to deliver this care and measure outcomes so that we can fund and sustain this work. So that's what I'd love to see us make progress on in the next 3 to 5 years.
All right, Jim.
I suppose in 5 years, if I had my druthers, there'd be 3 areas that I would really like to see forward progress. The first is I would like the Washington State Department of Health to establish a scope of practice for community resource paramedics, a definitive scope of practice. And as a paramedic, for all the paramedics maybe in this meeting, there is a very defined DOH scope of practice. And some of the skills that you're able to do as a paramedic autonomously without even talking to a doctor are very invasive. Everything from sedating and paralyzing and intubating a patient to sticking a needle in their chest and giving 50 independent medications without even having to speak with anybody else. And that's what you're trained to do. But community resource paramedics don't have a scope of practice that defines these areas that are used to serve life-threatening illnesses. In other words, I can do all these things, these really invasive procedures by myself, but I'm really not allowed to do a dip urinalysis in someone's home to determine if they have blood or proteins in there and to try to identify if they have a UTI, which will head off sepsis. So, and that's problematic. And so essentially we don't have a scope of practice as community paramedics to deal with those who aren't immediately in life-threatening situations. And I can do all these things, but we're not empowered really to fix this or head it off and treat somebody with $1.50 worth of Cipro. And so that ends up with very poor outcomes. Secondly, I think a big one would be shared lines of communication between our community resource paramedics and the other providers, home health care providers, physical therapists, primary care providers, social work. There really is a very haphazard and convoluted system whereby we get this vital information to those who really specialize in serving the patients that we're seeing. And that's the second area that I'd really like to see improvement. And lastly, which is probably a fundamental thing for fire departments, which keeps them from establishing CRP programs, is reimbursement. It's great to have ACH funding, but is it sustainable? Odds aren't good. And so, we have no means by which CRPs can go and do these preventative healthcare measures or see these marginalized patients. We have no means by which we can get reimbursed as fire departments. So, the bottom line being, we're essentially using our work hours and providing these to benefit, to provide benefits, but we're not getting any money for it. So those would be the big three.
Okay, Alessa.
So what I would like to see is the continued growth of these street medicine programs, or at least from that model, where my personal goal and my team's goal, Consistent Care's goal, is to try to continue working every day to progress decreasing stigma around those who are unhoused and bring more education to the streets, to the providers, to the PCP offices, anyone who works with some of the patients that are coming in. We've had a couple of examples where we've taken a patient from the field into a PCP to establish, and they were not treated very kindly at the receptionist site. And I believe that's only going to come with education and experience. And so that's what I'm hoping to accomplish in the next 5 years, is just to put out a broader, keep doing what we're doing, continue to hire people so that we can serve more. I would like to grow and expand our services more in the rural areas. I see a lot of need in those areas for programs such as street medicine. And that would be my personal goal for what I see in the future.
Awesome. Thank you all so much. And I am getting lots of messages that we have many questions coming up through the chat. People are raising their hands, they're sending messages in different ways. So what you all don't see is this machination that Elizabeth and Stacy and I have to do of like, so what do we do at the breakouts and blah, blah, blah. So we're going to send you still into the breakouts, but it's going to be shorter. And they're going to be like 2 questions for you. And then when you come back, if you have a question for the panelists, we're going to just create some time for you to be able to ask those questions. So it's going to be like, what jumped out at you so far? And if you've got a question that you want to elevate, if you can just craft it so that when we come back together, we can pull those forward. So someone is, let's just see, Natalie, going to do like some breakout rooms. They're going to be groups of 3 or 4. It was going to be for 10 or 15 minutes. I think it's going to be for like 5 to 7 minutes. And hope to see you all when we come back. So Natalie, I'm turning it to you.
Conversations, we've run out of time in our work group. So anyway.
Okay. Hello, everyone. Welcome back to our shared space. I'm very excited. It sounds like there was some really great conversations that were taking place. So to kick off being in a shared space, would anybody like to share out with the larger group some discussion topics, some questions that came up that we can maybe ask our panelists? Anything that anybody would like to go ahead and share out? It looks like there's some comments in the chat here. I know people are still coming back into the group. Is anybody interested in sharing out some questions, some interesting topics that were brought up in our small groups? It looks like it looks like if you could please raise your hand, I will go ahead and go accordingly. So it looks like Heather, your hand was raised, and then I have Mario next up.
Yeah, and actually, I think it was Seema trying to unmute herself, and I might ask her to share because these were mostly her questions. But yeah, our group was just really kind of got the wheels turning. This is a really interesting, a lot of questions and curiosity was sparked. So we were just really excited and interested for this conversation. But Seema, do you want to share the questions that you raised?
Yeah, so I have 3 questions. Number 1, what language are they using instead of high utilizer? Second question is, what is happening for patients who are discharged from the hospital, especially elderly patients? Do paramedics follow up with them? What kind of role do they play with elderly population, Medicare population? And my third question is in area of transportation, what kind of support do they provide so that the patients are not meeting their appointment with the primary care physicians or with their providers? Those were my three questions. And is there an area where we can work together in this? I see a lot of opportunities in this area.
Yeah, thank you so much, Seema, for asking those questions. It looks like Liz went ahead and answered one of them. It sounds like typically instead of using high utilizer, we're using familiar faces. And did any of the panelists want to go ahead and tackle some of the other questions that Seema had brought up?
Well, as far as transportation goes, if we, through the fire department, realize that transportation is a barrier for one of the people that that we're interacting with in the community, we do have the recourse to set up through the Tulalip tribes and utilize their transportation services, which include a lift gate for those who might be in a wheelchair. And so we can, if we can identify that patient who needs that transportation, we can utilize that service. A lot of patients that I've seen, I have literally taken them to their appointments, taken them to the pharmacist in my command vehicle. And so, and I provided that. It was the path of least resistance and the most expedient. But we do have some transportation services available to us, but they're still limited. And that's a really good question. As far as the follow-up with the discharge of patients, particularly tribal elders or the elderly in the field of geriatrics, that is a barrier. It is a barrier. Now, the Tulalip tribes, through their community health program, have a fantastic, dedicated liaison, is the word I'm looking for, who does those follow-ups. And what the liaison does is deals with the discharge planner in serving that patient who's getting discharged from the hospital. And that will often incorporate collaborating with our community paramedic program for ongoing evaluation.
Yeah, thank you so much, Jim, for tackling those questions. I really appreciate you spearheading that. Mario?
I can answer, oh, sorry. Can I answer that real quick too,
Yeah.
as well? So as far as our consistent care, we will connect them to services like HopeLink or something like that as well. We also will pay for an Uber if needed. And then the last thing is we actually have a company vehicle. So I have they function as CHPs, but they are CHWs, but they our client advocates will drive them to their appointments to the pharmacy, what they need as well. The other thing that I just want to comment on was the term of high utilizers or, familiar faces. I love familiar faces. That's great. But going back to the business model of healthcare not being the most friendly when it comes to the professional terminology, it still is high utilization, just so you know.
Thank you, Lisa.
Uh-huh.
Mario, did you want to go ahead and ask your question or make a comment?
Yeah, I'll invite others in the group that we were in to discuss the other things we talked about scope of practice. But I do have to jump to another meeting real quickly. But I wanted to make sure to say that one of the things that we learned from the pandemic was that the administrations gave some special privileges to certain workers, like essential workers could travel certain times and could do other things that others could not. And so that definition of essential worker, whether that be working with EMS or other, community health workers, medical assistants, providers, et cetera, how for scope of practice, if we had an emergency, another emergency, we just had a fire here recently, whatever that emergency is, if we can define a scope of practice as an essential worker, that has certain core competencies, and maybe that could help alleviate during a pandemic or during an emergency or whatever. We can say, you know, we're allowing the essential worker to be put into to be implemented and do all the strategies that they have to do. And so I don't know if I'm kind of explaining myself correctly, but basically have a scope of practice for an essential worker, whatever that is, whether that be, it can be a community health worker, EMS, it could be a teacher, but if they have that core competency of essential worker, then we can go ahead and provide a scope of practice. We can provide funding that's emergency funding specifically for those instances to go along with helping all the great things that EMS is doing as well. And then the last thing is, how do we help you in order to move forward along with that scope of practice? Do we talk to coalitions? Do we talk to legislators? Do we send emails? Do we talk to people? What is it that we can do to help you to move that definition of scope of practice forward?
You know, I think I can help tackle that, Rajdeep, if you don't mind. So a couple of things. One of the things that occurred during the pandemic was some of the things you're talking about, Mario. So paramedic scope of practice pretty limited. For example, as Jim alluded to earlier, you know, we can do a lot of things to save a life, you know, IVs, intubation, cardiac drugs, emergency drugs, etc. But at the same time, the state didn't allow a paramedic to give a flu shot. And, you know, it wasn't in the scope of practice. It wasn't in the formulary. So when the pandemic did hit, they put into place some emergency orders that allowed paramedics to give, actually it allowed paramedics and EMTs, which was a really big reach, to give vaccinations as well as do testing. And so there was recent legislation that went through, and actually that was forced through by a couple of our representatives to give that as a permanent scope of practice for paramedics, which I think just passed through recently. So yeah, we can give flu shots, but to your question, for the wider scope, that's exactly what needs to happen, which is further define what that is. And Jim's talking about we would define an entire legislative scope of practice, areas that can work in, along with identified training that would go with that. Because the other part of community paramedicine is motivational interviewing, case management, social worker information, and we just don't typically have those skill sets. And then some of the other clinical stuff just related to, you know, skin care and daily activities of living and wound management and all that stuff, which paramedics can easily learn to do, and most already know how to do that. So for moving this along legislatively, yeah, that's exactly what we want to do. We want to put this scope of practice together to define all those components of that scope of practice, and then hopefully we can get some representatives to help us push that through the legislature, and then of course through our EMS and Department of Health committees that push that up. So that's exactly, I think, where we'd have it. Yeah, and as the chat pops up, we want to codify some of these that are integrated with that larger health system. So that is the work to do, Mario. Thank you.
Yeah. Thank you so much, Mike, for answering that question. You actually read my mind. I was thinking you would be the perfect panelist to go ahead and answer that. And I am keeping an eye on our clock, and we are nearing the end of our time here together. So I just want to make sure that I do thank everyone for coming in today. I want to thank all of our panelists for their wonderful responses and the questions and areas that we were able to kind of dissect together. So I really appreciate the conversation today. If there are any other questions that we missed, please don't hesitate to go ahead and email us, and we'll go ahead and pass that out to our panelists to make sure we get those responses for you. And then just a reminder as we're wrapping up to please explore more of the resource library. There's links, recordings, slides, and today's session will also be posted in the resource library soon. And I think Stacy will also, she's already on it. The resource library link is in the chat, so feel free to roam in there. And then also we'll be sharing a link in the chat to the survey about today's session, and we'll appreciate your feedback. So if you have a moment to go ahead and click on that as well. But we are at time, so I just want to say thank you, and I hope you all have a wonderful rest of your week.
Thanks to all the speakers. I really appreciated it.
Thanks for the opportunity.
Thanks, everyone.
Thank you.